Okay, let's kick things off. So thank you to all of you who've joined. You made it to the climax, as I've been jokingly referring to, of the summit. We're at the closing plenary session, and I have two lovely guests with me who I'll introduce shortly. Not to belabor the point, but you'll have recognized that your microphones have been muted just to ensure we can have a nice, smooth presentation. Also, if you have any questions, please feel free to submit any questions, any thoughts by way of the Q&A. We'll do our best to respond to them during the latter portion of the session, during our Q&A period. Also, please do keep all topics or questions or suggestions on theme. And we really appreciate the fact that you've all been able to participate on what is the closing plenary of our day one of the SCAGO Sickle Cell Disease Summit. Also, towards the end of the session, we'll be delivering a post-session survey along with a post-summit evaluation, and your participation in both are very greatly appreciated as it allows us to course correct in real time and make sure we offer you the most optimized experience. Okay, so with that, joining me on the screen, as you can see, we have Sudha Kutty, a former director of mine, funny enough, in a previous life. Sudha Kutty is Executive Vice President, Evidence, Products, and Services at CADTH, she's responsible for leading CADTH's pharmaceutical reviews and medical devices and clinical intervention portfolios. She's recognized as a seasoned healthcare executive with over more than 25 years of strategic healthcare leadership experience. Sudha is passionate about healthcare, and she brings a wealth of experience in promoting health system improvements by actively supporting the adoption of evidence into practice through various healthcare campaigns, developing continuous learning and educational opportunities, and leading organizational change through equity, diversity, and inclusion initiatives. Prior to joining CADTH in January of this year, Sudha served as the Vice President of Strategy and External Relations at Humber River Hospital. And prior to that role, she was the interim vice president of quality improvement at Health Quality Ontario, now known as Ontario Health. She holds an honors Bachelor of Science in Human Biology and International Relations from the University of Toronto, a degree in law from the University of Western Ontario, and an MBA from the Rotman School of Management at U of T. She's also a member of the Law Society of Ontario. Thank you so much for joining us today, Sudha. Next, we have Heather Logan. Heather is a Vice President of Strategic Relationships and Initiatives at CADTH. In addition to heading up CADTH's post-market drug evaluation program, she oversees the organization's external engagement functions, including meaningful partnerships and identifying innovative opportunities to strengthen CADTH's relationships with decision makers, patient, and healthcare provider organizations, Indigenous peoples and communities, the pharmaceutical and medical devices industry, and other stakeholders across pan-Canadian health systems. She's also responsible for helping the organization take meaningful action and drive sustainable culture change to support equity, diversity, and inclusion, both internally at CADTH and externally for other stakeholders. With nearly 30 years of experience working with local, provincial, and national decision makers, Heather is known for her facilitative leadership style and for being results-driven. With a background as a nursing officer in the Canadian Armed Forces, a healthcare administrator, and a systems leader, she brings a unique and collaborative perspective to her role at CADTH. So with that, I'm going to share my screen and allow us to participate in what is our closing plenary session for today. Over to you, Sudha.
Great. Thank you so much, Delaney. It's really a privilege to be here. I just have to apologize in advance. We're having our bathroom renovated and they were to be done by now, so they're not. So you might hear a little bit of banging, so I apologize for that. Firstly, I'd like to begin by acknowledging that I'm speaking to you today from Toronto, which is the home of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And really on a day like today, when the sun is shining so brightly and the trees are full of fall color, I really want to thank all the Indigenous peoples who have been the keepers and stewards of this land since time immemorial. A real thank you to SCAGO for the invitation today. The speakers have really been fantastic. And it's really an honor for Heather and I to be the closer for today's session. So on the next slide, I just want to share our disclosures our objectives rather for the session. We really want to provide a very high-level overview of CADTH and our strategic plan. We've been asked to provide an overview of our processes for the review of drugs and devices. And really, we also want to share how CADTH engages with patients and clinicians, and how can patient and clinician communities become engaged in CADTH's work. On the next slide are our disclosures. So we're both employed by CADTH. CADTH is funded in part by Health Canada, as well as the provincial and territorial governments, as well as a percentage of our revenues in our pharmaceutical review program come from industry. So those are our disclosures. So the next slide sort of shares a little bit about who we are. So CADTH is Canada's Drug and Health Technology Agency. We were established in 1989 by Canada's federal, provincial, and territorial governments to really be a trusted source of independent information and advice for our publicly funded healthcare systems. And healthcare administrators and policy experts have come to rely on CADTH to inform their decisions about this concept of the life cycle management of drugs and devices and services that are used to prevent, diagnose, and treat medical conditions. On the next slide, just a little bit more detail. We really focus on the effective management of drug and health technologies in Canada. We are experts in scientific research. We understand even more so now than ever the importance of timely, relevant evidence to inform decision-making, and we provide guidance in a rapidly changing environment. Just on the next slide, a little brief bit about our history. You can see we were established in 1989, a sort of precursor through an organization called CODA. And we've evolved over the years, including a merger of two programs into CADTH, and we are here today in 2020 with over 200 employees and really positioned to be that pan-Canadian trusted source of evidence on drug and devices. We launched in 2022 a very ambitious strategic plan called Ahead of the Curve, Shaping Future-Ready Health Systems. Funnily enough, we had an information session yesterday, and our CEO commented on how many people have told her what a great strategic plan this has been, and how many people have been attracted to join CADTH because of the strategic plan, myself included. So it's a really wonderful plan, and really is about us moving forward as an organization. On the next slide, you can see what the strategic pillars are of our strategic plan. It's really about anticipating, so ensuring that our healthcare system is future ready. It's about innovating, really thinking about how do we unleash the value of technology across the lifespan. And then it's really about transforming, so catalyzing health system change. I firmly believe that the strategic plans, it's not just about the pillars, it's about the principles underpinning the plan that are important. And on our next slide, we've listed our guiding principles. So as we're looking at these three pillars, we're really looking at the underlying principles, thinking about our overall impact, thinking about agility, thinking about how do we work in partnership, thinking about equity, diversity, and inclusion. And more recently, we've added accessibility. So this pillar is now actually about, or this guiding principle is about IDEA. And then lastly, but not least, transparency. So these are sort of the five underpinning guiding principles that sort of support how we engage in the work and further our strategic plan. So on the next slide, it's a little bit of a busy slide, a really great article if anyone has had a chance to access this, and if not, happy to share a link with SCAGO. But this is really what a definition of health technology assessment is. And it's a multidisciplinary process that uses explicit methods to determine the value of health technology at different points in its life cycle. And the purpose of a health technology assessment is to inform decision-making to promote an equitable, efficient, and high-quality health system. And so it really kind of gives you a bit of a sense as to what it is that CADTH does in this space of health technology assessment, otherwise known as HTA. So I'm going to sort of break my presentation up into two buckets. I'm going to first do a quick overview of how we do HTA in the drug space, and then a quick overview of how we do HTA in the devices space. I'm then going to turn the podium over to my colleague, Heather Logan, who will really talk about our work in the idea space, and then probably even more importantly, how we engage with clinicians, how we engage with patients, and how you can get involved in the work of CADTH. So on the next slide, I joined CADTH in January, and it took me a little while to sort of really parse and unpack what is it that CADTH does that's different than Health Canada. And so this slide is an attempt at summarizing that. So Health Canada really looks at a drug and says, is it safe and does it work? So it's a safety efficacy kind of analysis. CADTH then does this health technology assessment of the drug to look at how does this particular drug compare with existing treatment options, and is it good value? We then have another a player in the space, the Patent and Medicines Prices and Review Board. They look at whether the price of the drug is excessive compared with other countries. And then we have the public drug plans and the PCPA, which stands for the Pan-Canadian Pharmaceutical Alliance. And they ultimately look at, is this drug needed? Is it affordable? And then move on to negotiate the price. So just in a summary on the right-hand side, the role of the regulator, Health Canada, really is about regulation of the drug. Does it work? What are the risks or side effects? Are the benefits greater than those risks? And was the manufacturing process a quality manufacturing process? CADTH then goes to the next step and says, how does it work compared with existing treatments? Is it better than what we already have? If there are no existing treatments, how does it compare with the current standard of care? Who does it work for? So in what group of patients? What is the value? So is it cost effective? Are there any implementation issues to be considered, such as health human resources or location of care? And so forth. And so this is kind of the difference between what the role of Health Canada is versus what the role of CADTH is. On the next slide, just an overview of sort of what's in scope for our reviews. So CADTH reviews new drugs, we review new indications, we review new combinations and new formulations. What is out of scope? We don't review vaccines. That's the role of the Public Health Agency. We don't review drugs that are only funded by a hospital payer, that are used only for diagnostic purposes, that are non-prescription, or that are generics or biosimilars. We don't review natural health products. We don't review anything that's indicated for nutrition or electrolyte imbalance, and the drugs that are under the Canadian Blood Services formulary. So just a little bit of sense of what's in scope on the left-hand side and what's out of scope for CADTH's work. On the next slide, also a little bit of a busy slide, but it gives you a bit of a sense of how we do our work through the reimbursement review process. So we have the initial submission that is made to CADTH. We then have advisory group input from the provincial drug plans, and we also have stakeholder input from patients and clinician groups. And so this is the opportunity for clinicians or patients to provide input into the overall CADTH review. All of that input is pulled together and brought before an expert committee. The expert committee has a public member who sits on the committee, and their role is to help summarize all of the patient input. The expert committee will also have, in addition to the clinical experts around the committee, they'll have additional clinical experts who come in for that specific topic or drug. And all of this together is used for the expert committee, which is a deliberative panel, to make their ultimate recommendation. And the recommendation really looks at how, as I said at the top right-hand corner of the slide, how does this drug compare with existing treatment options, and is it good value? And that recommendation is ultimately made to the public drug plans for them then to act on. The recommendations are non-binding. They typically are picked up, but there are recommendations for the drug plans then to determine next steps. One of the concepts I've been talking about recently is, in my observation, the drug reimbursement review process is a bit like a relay race. Everybody has a part to play. Health Canada, as the regulator, has a part to play. They're holding a baton, which they then hand off to CADTH. We do our part. We take our baton, we hand it off to the PCPA, the public drug plans. So we all have a bit of a part of this process of ultimately getting drugs listed and out to Canadians. This slide kind of shows you a little bit of the intricacies of what goes into our recommendation. Great, thanks, Delaney. So a lot of information around clinical trial information, the economic model, indirect comparison information, and then budget impact assessment, along with stakeholder input, ethics review in certain cases, and implementation information. And all of that together forms the overall recommendation. So this sort of gives you a sense of getting drugs to listing. We also have a program that we launched about a year ago called the Post-Market Drug Evaluation Program. And so on this graphic, you can sort of see the trajectory of a drug, which sort of starts off with a bit of early scientific advice, the formulary and reimbursement review that I just talked about, and then this idea of post-market review. So really it looks at what happens after something has been listed and what does that look like, and are there any challenges from a safety or efficacy perspective. And so this is some ongoing work that CADTH has engaged in to really support that full life cycle management of a drug. I know that was a bit of a whirlwind. I'm now going to pivot to devices because I do want to allow time for Heather to go through engagement and then also for your questions. So on the next slide, a little bit about how do we support decision-making on medical devices and clinical interventions. We have a series of products that are a current state, for lack of a better word, and then a product that's a bit more future forward facing. And that's our Horizon scanning service in the little green puzzle piece. So on the next slide, our future forward horizon scanning piece really looks at new and emerging technologies, early assessment of technologies, system preparedness, and really informing overall health technology assessment. So here are some samples of recent horizon scans that we've done. And so you can see by the names, they're very forward facing, they're very futuristic. And the role in horizon scanning is to sort of alert the system to the fact that this is something that is coming down the pipe or is already in play and something for decision makers to be aware of. Some of the upcoming horizon scans we're focusing on right now is around artificial intelligence and the role of AI in healthcare. On the next slide, we also do a series of environmental scans, which are a bit of a snapshot of what's currently happening in current practice. And here you have an example of one that we recently completed around the role of telephone triage services in Canada. On the next slide, we also, in an effort to fill jurisdictional needs for evidence, we have a rapid response service that has products that we turn around fairly quickly within 6 weeks, in some cases to 12 weeks with expert input. And here's a fairly technical rapid response that we recently completed. The role of a rapid response is to sort of have an abbreviated review of the evidence in a rapid turnaround time to meet a current need that the system is asking of us. And then on the next slide, sort of probably our largest scope of work is around our broader health technology reviews, where we use this deliberative framework, which is noted in the right-hand side, looking at different domains and assessing a particular technology or model of care against those domains, using a health technology expert review panel to provide advice and guidance. Through these broader health technology reviews, we get patient, caregiver, and clinician perspectives and engagement throughout. And as I said, we also look at including implementation considerations. On the next slide, another big initiative we're involved in, and I want to point this out for obvious reasons, is we have an annual report every year that looks at emerging technologies that have the potential to shape the future of healthcare. Our 2023 annual report called the Watch List was around precision medicine, and we identified 5 technologies and 5 cross-cutting issues in the space of precision medicine that could guide health system planning. Our 2024 watch list is on children with medical complexity. So obviously a topic that is near and dear to the hearts of SCAGO. And we are anticipating to launch this watch list in 2024 in February. And I believe I know that SCAGO has already reached out to engage in this initiative. So have an eye out for that project. On the next slide, this is just a bit of a depiction of some of our recent health technology reviews, and you can sort of see some large topic areas such as emergency department overcrowding, models of care for managing long COVID, in the mental health space, peer support programs, early intervention programs for eating disorders. So it just sort of gives you a little bit of a sense of some of the work that we do through these broader health technology reviews. On the next slide, I'm not going to belabor this slide, but basically within both the medical devices and clinical interventions portfolio, as well as the pharmaceutical reviews portfolio, we have a variety of advisory committees and then expert committees. The advisory committees, as the name would suggest, really advise us in terms of how we do our work. The expert committees are the deliberative panels that actually deliberate and make their recommendations to ultimately inform a decision. And as I said, Heather's going to speak a little bit about how to engage through CADTH and with CADTH, but I just wanted to sort of put up there that there are different methods and different modalities for engagement. I think with that, I'm going to turn things over to Heather. Thank you.
Great. Thank you very much, Sudha. And I want to just say thank you to SCAGO for inviting us to both join you today. It's just such a pleasure to be here. And we're really looking forward to the opportunity one day in person to make connections with you in ways that sometimes you can't do on virtual spaces. So I've listened to many of the presenters today, and what a rich day, what a way to end the day, and what a terrific series of presentations as you talked about commitments to address safety in healthcare, anti-racism in healthcare, inclusion and diversity, and the work that's happening across the system for patients and families who are living with sickle cell disease. So I want to talk to you a little bit about patient and clinician engagement. And I know that through this audience, this presentation will be posted. I encourage you to talk to your colleagues, talk to other people you know, share information about this. We want and really need people to participate in CADTH's work. It gives us a lived experience, which I'll tell you a little bit more about. Next slide, please. So you've heard a little bit about our strategic plan. What I want to just reinforce with you is that our strategic plan commits us to anticipate what's coming in health technology. So we see advances in drugs and devices, clinical interventions, but not just that we see them, that we're trying to innovate how the system is able to implement and use those technologies in the best way possible, and really just to support jurisdictions in the implementation of that work, all for the benefit of patients. We actively listen, learn, and get better in the work that we do because of the commitment we've got in our strategic plan, and because we hear directly from people who are living with the diseases that the technologies are intended to support. So that strategic plan really puts firmly the importance of hearing from patients, hearing from equity deserving groups, and reflecting those perspectives in the work we do. Next slide. So why do we engage clinicians? So you saw a couple slides ago, Sudha showed you some of the structure in the organization from advisory committee to expert committee. She also talked about some of the reports that we release. We release reports that analyze particular issues. We release reimbursement recommendations about drugs and devices. All of that is better when we are able to understand the real life experience of living with a disease, the real life experience of using the technology that we're evaluating, and understanding what the impact of the current situation and new technologies might offer. So in many different ways, whether it's patient input that's provided in writing as part of a process, sometimes our patient engagement team will reach out and meet with individual patient groups to have a conversation about that technology and what it might mean to them. But all of that is predicated on getting that information to a process so that it becomes real and tangible. And it isn't only an academic look at the clinical literature or the economic literature. We understand at the end of the day, experiences can be quite different. And the richness of those experiences is factored into all of the work we do across all of our processes and all of our products. Next slide. So there's a link here at the bottom. Sorry, we'll just go back up one slide. There's a link here at the bottom that gives you some information, and there's lots of other links from there that will show you how you can get involved. So I encourage you to explore. If you have questions, I'll make sure that SCAGO has a couple of key contacts, including my own, if you have questions about how to get involved. Next slide. So we like to talk about the work we're doing with, for, and about patients, caregivers, and families really in this way: relevance, fairness, equity, legitimacy, and capacity building. So I'll go through each of those just very briefly. We want to make sure that we seek patient perspectives, caregiver perspectives, and family perspectives about the quality of our assessments of medical procedures, drugs, and devices. It makes it better, it makes it richer, and I spoke about that a minute ago. Next, when you want to think about fairness, there are choices that will have to be made across health systems. Budgets are finite, and those choices can be difficult. We want to make sure that decision makers have not only the best evidence, but the richness of those perspectives of individuals who are living with these diseases and the technologies. It makes sense that patients and the public be aware of and involved in our work, since those choices are societal choices about how we allocate resources that we have. Next, if you think about equity, we've talked a lot about this, and I've listened and learned so much today from your speakers about equity and how you're thinking about it. But we can, through this process of listening to families and caregivers and clinicians, offer insights about the diversity of individuals and healthcare settings across the country. We are not all located downtown Toronto or downtown Vancouver near a big hospital. Some of us live outside of those centers, have difficulty accessing healthcare, or have different access issues related to those technologies. Understanding those complexities and reflecting those in the kind of recommendations and analysis that we do gives decision makers a better sense of what it means to use that and have access to that technology. Fourth on the list is legitimacy. Your involvement in our processes, having individuals who are affected by these technologies involved in the processes, they understand how the processes, the discussions take place. And at the end of the day, if there are recommendations, devices, and part of that is capacity building. I can see my internet capability is slow. Are you still hearing me okay? Okay, great.
Yeah.
We want to make sure that we can use information, evidence, and appropriate use of those drugs, and that includes with the individuals who are participating in our processes. Next slide, please. So this slide shows on the top hand in blue, you'll see some arrows. This is the International Association for Public Participation Framework. It really has 5 main categories, from inform to empower on the right. Inform is a very transactional kind of approach. We've released a document, we're letting you know. Empower, on the other hand, is co-creation, being able to come together around a particular problem and identify how to move that forward together. We want to, at CADTH, both increase the number of patient voices that we have around the table generally, so in more products, in deeper ways, but we also want to move from inform all the way over to empower. We want to be able to listen to the issues within your community and other communities and make sure that those are reflected in what we do. And so there's a couple of examples in this, from sharing information about the reports that we've done to, on the far right, as Sudha had mentioned, we have patient and public members on 3 of our expert committees. And in fact, recently, through something called the Formulary Management Expert Committee, we have patients that come with an association and they present directly to an expert committee. They share their personal story, their personal experiences, and the committee has an opportunity to ask questions about those experiences and the use of that particular health technology. Next slide, please. We have lots of different ways to try and find patient contributors. There's some listed down the right-hand side. In fact, we have 17 right now, and we're always looking to expand. Looking at patient and family advisory committees within hospitals, for example, people who are vested and already have experience in some of the bringing patient voices into decisions within hospitals. Looking at social media and who's talking about the use of a technology or problems around access to treatment, and reaching out to them and bringing them into the organization. We have an annual conference that Sudha mentioned called our annual symposium, and we do actively support patients to participate in that and get a designation for patients having helped design that conference. I'd encourage you to come, help us understand, build relationships with us there as well. We have open calls for expressions of interest, so on our websites, and we actively, when we know a product is coming into the organization for review, our engagement team will reach out to the patient organizations that we can find, so through an internet search, through our existing connections, to find out which organization might be most interested in that particular review. So if it was a product to treat sickle cell disease, we would come to this organization, to others that are affected in hemophilia, for example, and blood products, and let them know we're having a submission. Give them an opportunity to provide input, and also then to look at the recommendations in advance if they've provided input. Next slide, please. So this is just a visual example of some of those 17 different ways people can contact us who build a relationship. We have calls for input, partner organization, patient groups are aware of in this space, stories in the news that talk about those patient stories. So things that we see online, we understand some of the leaders that have come today, and we watch those things to find people that we can bring in and help us understand, your experiences. Next slide. So this is not the actual expert committee that Sudha mentioned. We have 3 of them, PERC, which is an oncology drug committee, CADTH, which is a non-oncology drug committee, and FMEC, or Formulary Management Committee, which is a new particular expert committee. So this is an example of what that committee would look like. Next slide. So who does provide input into the work at CADTH? So patient groups, a patient group is an organized group that represents patients with specific disease or condition, like SCAGO, or a collection of diseases if they represent cancer collectively as opposed to a specific type of cancer. Any patient group, obviously including SCAGO, can provide input. We hire from small Facebook groups to large national charities. So it's the full range where we can go and get that input. We would accept that from a group. 2, we accept input from clinicians or clinician groups that have experience using this particular technology or experience treating the condition. Between January and June 2023, patients and clinicians were involved in 48 reimbursement reviews. See, these are drug products where manufacturers submit. We invite people to participate and give us input and review recommendations. And that includes 58 patient groups and 48 clinician groups. So we work really, really hard at this. Next slide. I won't go through all of these. There are many ways that the patient input is used in reimbursement reviews. I've mentioned a few of them already. It helps us understand the impact of an illness on a person's life. I heard many of the presenters today talk about pain management, and the approaches that are used when people are in crisis. So that helps us understand the impact of a treatment and the reduction of those potential scenarios. We want to appreciate the goals of treatment and what it means to have those met or to not do those if a particular drug isn't available. We want to help understand clinical trials practically. You can see the impact of side effects in a clinical trial, but to understand the impact on a patient and the impact on patients' families is something you can't get unless you hear from people directly. Obviously, equity, diversity, and accessibility are something that are really important along with ethical considerations. So lots of different ways that we can use patient input and reimbursement reviews. Next slide, please. And I think I'm very close to being finished. I know we're getting close to the end of time. There's lots of different ways for patient members. Mr. Frank Gavin has been involved in many, many parts of CADTH's work. They provide a voice, patient perspectives to the work that we do. They actively participate in discussions. So at our expert committees, we have representatives who sit at the table who represent those patient voice, and they are equal active participants in that discussion. And of course, as part of that, they also are voting members. So this is equal participation in the process, and we're looking to expand that across the organization. Next slide. Clinical experts. This is an area, our information session yesterday, this is an area that I'm particularly excited about coming to and working with SCAGO on. We do work pretty carefully and extensively with clinicians. We find clinicians who have experts, again, treating the disease and maybe using the technology if we can find them. Sometimes that's not possible, we work very hard for that. They will come to expert committees and share their experience. They answer questions from the expert committee and will participate in part of that discussion. And that gives us that on-the-ground expert experience. But we also establish clinical panels for specific drugs. So for example, these panels can help us understand unmet therapeutic needs. They can help us understand and identify situations where there are gaps in evidence, potential implementation challenges, and also understand the clinical management of patients living with a condition. It may look a certain way on paper, and in practice, clinicians and patients' experience can be quite different, and it helps us to understand those particular experiences. And also look at where a drug fits in therapy, whether it is a first-line therapy or whether it might be used more effectively downstream, and what the experiences of people have been. Next slide, please. So I'll stop. I'll end with, we are here for conversations. If you're in the room and you're a clinician and you want to be involved but haven't yet, please reach out. We look forward to working with SCAGO and to the opportunity to meet you in person. Frankly, we can't do our work well without you. Thanks very much for the opportunity.
I knew I called it a climax for a reason. Thank you so much for bringing to bear all of that very insightful information and doing so quickly. I know we could probably spend the entire day talking about both the process that CADTH delivers so well as the way that folks can be engaged. So thank you, Heather. Thank you, Sudha. We're your complete gratitude. There's one question that's come through so far in the Q&A, and it reads, what is being done to ensure safety and reliability with devices like pulse oximeters and dark skin, for example?
Yeah, such a great question. I'm happy to start with it, and Heather, I'll happy to turn it over to you as well. So this is actually something that we're aware of. We have been looking as to whether we can do a bit of a horizon scan on this topic, or a bit of an environmental scan on this topic. Just a reminder, it's really Health Canada that looks at the safety and efficacy of a particular device and licenses the device. What CADTH can do is bring to light through the evidence the fact that clinical trials were not tested on patients with skin of darker color, and some of the equity considerations that brings to bear. And so this is a topic we're aware of, and it is something that we're trying to think about what can we do in this space. But just sort of separating out the role of the regulator in terms of licensing a device versus the role of CADTH in terms of reviewing a device or reviewing the evidence around a device, but definitely aware of it. I don't know, Heather, if you want to add anything.
I'll add to it, but probably from a systems perspective and how we're approaching who sits around the table at CADTH. The voices around the table are important. At every level of the process, where we look for board members, expert committee members, patient representatives, we are increasingly adding in questions to start to understand an individual's perspective on equity, and to make sure that the fabric of the Canadian society is represented at those tables. We did have a board member who flagged, for example, several months ago, some of the issues around the clinical review. And are these issues with equity deserving populations, different skin colors, are they being factored into how staff are reviewing that information, how it's being brought forward to an expert committee, and then how are they deliberating? So it is an area we have a new individual that started with the organization named Emil Reddy. Their responsibility is inclusion, diversity, equity, and accessibility. And they're working with teams across the organization to figure out how we ask the right questions and have the right perspectives at all of those different places across the organization. We're early in that process of really examining all of our steps, but we've brought that position on to make sure that we've got someone to ask them, to force us to really think beyond what we've done in the past and how we can do better.
Awesome. Disruption at its best. We have another question here. Someone's asking, what is reimbursement review? If you could clarify.
I can address that. And again, I apologize. It was a bit of a whirlwind presentation. I'm so happy to sort of explain in a little bit more detail. So the reimbursement review is the process of reviewing a drug and then making a recommendation to the public drug plans. We have 3 recommendations. One is reimburse the drug, one is do not reimburse the drug, and then the third is reimburse with conditions. So that is kind of our product. It's called a reimbursement review. That recommendation, though, to reimburse or not is made to public drug plans. They then determine whether to accept and adopt that recommendation. They typically do, but that's ultimately their determination. And this is in relation to the publicly funded drug plans, not the private plans. That's a separate process.
Fantastic. I had a question as well. This is for you, Heather. For someone who's new to the idea of sitting on one of these patient advisory boards, are there some type of training or orientation that takes place to kind of ensure someone feels equipped for success?
That's a fantastic question. So I'm going to answer that in 2 ways. Participating in one of the 2 expert committees, CDEC or PERC, they have permanent representatives from patient and public members. We work really hard to orient them to the work of health technology assessment, to what their specific role is in that panel. So their role is not to come necessarily, although of course though they're welcome to, and look at the clinical evidence that's being presented at the committee. Their role is to represent patients and public perspectives when patient groups submit information into the organization, to reflect that back, and then to honor those perspectives through the entire deliberation process. And so if there's a particular therapy that offers oral or intravenous therapy, and that's something because of the patient population that is particularly important, as that deliberation goes forward, they can continue to bring those principles up and remind the committee, remember, this is what we heard from the patient. So there is a patient voice reflecting that input at every step along the way. So we orient them to their work. We make sure that we support them along the way. They have 2 or 3 people at every panel member who are like themselves, so they can support each other. And we encourage that in the back end, so that they don't feel like they're there alone. They also don't feel like the burden of the committee's decision rests on how well they bring that information from the patient perspective forward. The second part I'll answer is around this new formulary management expert committee. So we bring both an association and an individual patient with lived experience to the committee deliberations. We work really hard to support patients before they get to the committee. It's an individual patient who may or may not have had experience presenting to. It's a pretty amazing group of people. And we don't want them to feel as though they, are nervous or shy about that experience, because we've asked them to deliberately for it. But that requires some discussion up front about what this is going to be like. But it also requires support at the back end. These are, many have had very personal experiences, and they're sharing those with a committee of strangers. And so at the end of that process, sure that we check with them to understand how to feel. Were there any impacts of presenting? And we do have a counselor available if that is needed, when there are particularly difficult stories that have to be shared to a committee. And so, yes, there's onboarding, but it doesn't stop at onboarding. We support them through the whole process.
Fantastic. Happy to hear that. I think one more question. I know we only have a few minutes before launching a poll, and Sudha, this question was more directed to you, in particular about your health technology watch list. You mentioned that there's a report that's delivered annually. How does the technology get on your radar to be included?
Yeah, it's a great question. I mean, our team, as part of that horizon scanning, is literally doing what the name suggests. They're scanning the horizon for what is new and novel and sort of out there. And so a lot of, reading of clips and reading of different newspaper articles and just being aware of what's happening. So, for example, we heard today in an earlier session about some of the gene therapies that are available in the States related to sickle cell. We're aware of them. We're kind of keeping an eye on them and just sort of watching as to when they're going to come to Canada. So we're actively looking at things like this. The particular watch list for 2024 around children and youth with medical complexity. It's a topic that we haven't delved into too much before, a specific focus on children and youth. And so it was one that the team really wanted to tackle. And there are a lot of complexities, especially within the SCAGO's patient population around children, medically complex care, integration of that care, all of the challenge, the burden of caregiving. So there's some really complex issues there that we wanted to tackle. And so that was the purpose of our watch list topic. But essentially, we're constantly scanning the environment to see what is out there that we want to flag for decision makers to have them get ready for what's coming.
Love to hear it. Okay, I'm just going to launch the poll for folks to participate in before we close the session. Being conscious of time, I just want to extend our, our overwhelming gratitude to both you, Heather, and Sudha, for basically providing a fantastic closing plenary for us to have learned so much in such a short period of time. It was both comprehensive and informative. We look forward to hopefully inviting you again at the subsequent sessions and having you explore the next budding question on your health technology watch list. Once again, thank you so much for spending this time with us. We'll definitely be sharing with folks the recording following the summit. I look forward to folks who are online to joining us tomorrow morning at 9 a.m. and also be on the lookout once we close this session for the post Day 1 Summit evaluation survey. So with that, I know we're currently at 4 p.m. and I want to be conscious of times in people's busy schedules. So on behalf of the SCAGO, I just want to thank you all for participating in Day 1 of our 2023 Sickle Cell Disease Annual Summit. And thank you once again to our speakers for providing us with such a worthwhile and jaunt in such a variety of areas for sickle cell disease. So thank you so much. Have a good afternoon and evening.
Thank you.
Bye.
Bye.